patient is in sitting position, and then you need to check from the sitting position when the patient is in facing to you. First thing you need to check what? First thing you need to take the permission from the patient. Number 2 thing, if the patient is female, you need to check that there is any attendance or not. There is any nurse present in front of you or not. You need to check. If there is any complaint related with examination, then avoid the examination or don't do the examination. If the patient is not giving any consent, don't need to do the examination. Is that clear? So first approach him that I am Dr. This, and then I want to do your examination. You do this one. I want to do your examination and for your help. And do you give me any permission to do this one? And then if you get the permission, such as she is female, so you need to check what other thing. If you are female doctor also, what other thing you need to check? Yeah, for her. You need to check whether there is any attendance or not. So call that attendance. And any nurse is there or not, call the nurse. And then you need to take the permission. And then you need to start. And then before starting, you need to ask the patient if the patient is male. Not the female patient. If the patient is female, the female patient can wear the underwear or undergarments. But in case of male patient, you need to open or off the upper dresses. You need to off. Okay. But in case of female, you need not to off the all dresses. You need to off the breathing also. Don't need to check like this way. No need to check like this way. You need to check. Just you come here and you need to remember. Yes, I need to check the odor. I need to check the odor of the breath. So odor of the breath indicates so many things. Now, well, most commonly phytohepatica, and then sometimes the bronchiectasis, foul smelling you found, lung abscess, foul smelling you found in the breath. And in some cases esophageal obstruction also, maybe foul smell. And in some cases, poisoning case, kerosene poisoning, the vapor of the kerosene can be felt by you. So you can understand, yes, it may be kerosene poisoning, like this way. So, and then you need to check what? At first, never forget to check what? Anemia, jaundice, cyanosis, edema, dehydration. Anemia, jaundice, cyanosis, edema, dehydration. So you can check it from this way. This way you can check. One by one, like anemia, at first anemia, and then jaundice, and then cyanosis, and then edema, and then dehydration. You can check like this way also. Or you can check eye. In the eye, I can check anemia, jaundice. In the tongue, I can check anemia, jaundice. In the ear, I can check the jaundice. Like this way also. But for the examination, if examiner asks you to examine anemia, so only anemia you need to check, only jaundice you need to check, and then only cyanosis you need to check, and dehydration you need to check, and edema you need to check. In front side, in this position, we only can check the facial edema. We only can check the facial edema. The facial edema checking, you need to check the lower eyelid. It is baggy or not. And facial edema, that is moon face or not. In some cases, facial edema indicates moon face. And then after checking this edema, you can check the anemia. Just put both hands. And very slowly, very easily, very comfortably. So the patient will not feel any problem. Friendly with the patient. And then tell the patient to move his eyes upside. And then you are checking the anemia in the lower conjunctival or palpebral conjunctiva. Lower palpebral conjunctiva. That is anemia. If it is white color or pale yellow, then it is anemic. And then what other side you need to check the anemia? What other side? Tongue. So you can tell the patient to move his tongue outside. So dorsum of the tongue you need to check what? Anemia. Dorsum of the chalk indicate what? Pale color? No. In case of anemia, there will be no papilli. This will be clear or plain. There will be no roughness. So you found in the tongue. In anemia, you need to check the tongue. And any other site of the checking the anemia? Palm of the hand or nail of the bed? Nail bed. You need to check the nail bed. Press the nail bed and you need to check the capillary filling is okay or not. It is reddened or not. Or it is slow. Like this way you need to check. You need to check all the nails or one or two nails you can check. You can check. That is the nail bed. And then you need to check the palm of the hand for anemia. Palm of the hand for anemia. Is that anemic or not? You need to check. You need to check. Or tip of the finger also. You can check like this way. So this is the examination of anemia. Examination of anemia. And then you need to check what? Jaundice. When you are checking jaundice, then you need to tell both eyes at a time. You need to hold the upper eyelid and tell the patient to move eyes downward, and you need to check onto the conjunctival area or sclera. Why the sclera portion, not the palpebral conjunctiva. You need to check the upper sclera. Upper sclera. If it is yellow color or not. If it is yellow color, then it is jaundice. And any other site of jaundice you need to see, that is under surface of the tongue. You need to tell the patient to do like this way. Don't tell, move your tongue upside, move it, not, don't tell. You need to show the patient, do this one. That is very easy. So patient can do this one. And you need to check whether, when you need to check the jaundice, you need to check that there is available natural light is there or not. You cannot put any torchlight there. Here. And then any other side to check the jaundice, any other side? Tip of the nose, air lobule, and jaundice you need to check the nail bed, yellow color or not. That is the thing. So anemia, jaundice, and then edema, dehydration. Edema you can see in the face only, not in the leg. No need to check now. Later on we will check edema in the leg. Just face edema we can check now. And then dehydration. Dehydration, how you can check? Just tell the patient to move the tongue outside and then put your finger onto the tongue. Then you will feel that this one is wet. In case of dehydration, my hand is clear. So if it is not wet, then it is dehydrated. Check like this way, whether it is blue color or bluish color or not. Fingertips and then allow the nasi, and then lips, and then air lobule. This blue color indicates the peripheral cyanosis. It indicates the peripheral cyanosis. For checking the central cyanosis, you need to check the tip of the tongue. Tip of the tongue. If tip of the tongue is showing the blue color, then it is central cyanosis, indicating the central cyanosis. Then we need to check the koilonychia and clubbing. Koilonychia mainly we see into the nail. Normally nail are convex. But if it is turned into the concavity, then it is called the koilonychia. And mainly one main cause of koilonychia, that is the iron deficiency anemia. And then you need to check the clubbing. Clubbing mainly it is the swelling in the base of the nail. But sometimes it is showing the swelled area. But you can check like this way. You need to put two middle finger. Same. The nail need to be placed like this way. And so in between the nail, see one diamond shaped space appears. One diamond shaped space appears. See, when you attach two nail of the middle finger, then in between the nail there is one diamond shaped space present. If present, there is no clubbing. But if there is no space present in between the nail of middle finger, then there may be clubbing present. So you need to see you need to show the patient to do like this way. To do like this way. No. See, only two finger nail need to be attached each other. Nail need to be attached each other. So there is a gap, diamond shaped gap present in between the nail. Diamond shaped space is present, then there is no clubbing. But if it is obliterated, this diamond shaped space you cannot measure or you cannot observe, then it is clubbing. Then it is clubbing. Now I need one this one. This is a reflex hammer. This is reflex hammer. So we need to check the bicep jerk and tricep jerk in case of upper extremity. We know this is the biceps muscle, and you place your thumb onto that tendon, and then place just third place onto that, press onto that tendon, just tendon. So this hand will be moved. So it causes the contraction of the biceps muscle. When you tap onto the bicep tendon, then this hand is moving. It means the contraction appears in the biceps muscle. Tendon. You need to feel the tendon and then place it like this way. And don't flex the arm. Don't flex the arm. You need to just slightly slide this way, and then you need to tap onto your thumb. Then you need to check whether there is movement or not, or biceps muscle contracted or not. So, and then tricep jerk. Tricep jerk you need to check. You flex the elbow and then you feel the tendon, that is tendon of the triceps muscle, and then just tap onto the tendon. And so this muscle will be contracted and will be extended. And this is called triceps jerk. Then you need to check the temperature, body temperature. With the thermometer, you can put the thermometer into the. It is clean or not? This is the clinical thermometer. This is the clinical thermometer. What is the difference between clinical thermometer and laboratory thermometer? What is the difference? What is the difference between clinical thermometer and laboratory thermometer? So laboratory thermometer you will find 0 to 100 millimeter, 100 degrees centigrade, or 200 degrees centigrade, 300 degrees centigrade thermometer is there. That is 0 to. But in case of clinical thermometer you will find 108 degree Fahrenheit. Upper level 108 degree Fahrenheit and lower level from 96 degree Fahrenheit. There is a mercury level present in the thermometer. Mercury level present in the thermometer. This mercury present here. And this mercury can push to downside like this way. You need to push the mercury, such as you check one temperature, someone's temperature. It is moved to 104 degree centigrade or 104 degree Fahrenheit scale. Then you need to move it to down again like this way. You need to shake this. Don't shake this like this way. So it will not move to that way. It will move to this way. So you need to shake like this way. So the mercury will move to this way. Okay. And then put the thermometer into the tongue, just below the tongue. And tell the patient, don't bite the thermometer. Never forget to tell this one. You need to put this thermometer just under surface of the tongue and tell the patient, don't bite. Just put it there for 1 minute. This is called core temperature or oral temperature. Sometimes we cannot put this one. You need to check 1 minute. You need to check the 1 minute. After shaking, you need to put it. You need to check whether the mercury level goes down to the below the 97 degree Fahrenheit or 96 degree Fahrenheit. Then you put this one, and then you need to check for 1 minute. And after 1 minute, you need to move out, and then you need to check against the white color. There is two color you found in there is water color and white color area. White color you need to put the against you. Against the white color you need to check mercury. Is that clear? You need to check against the white color of the thermometer. So you need to move out, and then you need to move your finger like this way, and white color opposite you, and then you need to see the mercury level, which level it is. Which level? it is. The temperature indicates by this way. So this is the code temperature. This is actual temperature. If it shows 102 degree Fahrenheit, then the temperature, body temperature is 102 degree Fahrenheit. And then you need to check the axillary temperature. Put here, and then this mercury portion you need to put in the middle of the axilla, and then tell the patient to keep it like this way. Okay, tell the patient to keep it like this way for 1 minute. After 1 minute, you will find the specific temperature. When you find the temperature, you need to add 1 degree Fahrenheit with that, with the body temperature. With the body temperature, you need to add 1 degree Fahrenheit. If such as you found here, you found 101 degree temperature. So actual temperature his body is, or core temperature is 102 degree Fahrenheit. 102 degree Fahrenheit. So like this way, you need to check the patient. And then you need to check the axillary lymph node. Axillary lymph node you can check like this way. First of all, put your finger very slowly. If you put like this way, then you will feel problem. Start laughing. Okay. So you need to tell the patient, I'm checking your lymph node. Don't worry. So you need to check what there are several groups present. So medial group, and then lateral group, and then apical group, and then central group. Apical group you found in the medially, and then apical group, and then lateral group, and medial group. You need to check. You need to check whether it is swell or not. Whether it is swell or not, you need to check. And then in front view, what other things you can check? That is the condition of the mouth cavity, condition of the nose, condition of the eye, condition of the ear, hair distribution from the front side, hair distribution of the chest. There is no hair in the chest, and so you need to check. It is also indicating something. You need to check that one. Hair distribution is okay or not, you need to check. And then you need to check the simple process of examining mouth cavity, nose and ear and eye. Simple process. We do not need any ophthalmoscope. We do not need any nasal speculum. We do not need any other thing. But only 2 things we need. One is tongue depressor. Oh, it is not tongue depressor.
Ice cream.
It is ice cream stick. It is ice cream stick. It is not tongue depressor. Anyone have tongue depressor? No, it is also not. One time use tongue depressor.
Sir, hospital.
Okay. One time use. So one time use tongue depressor you can take, and tongue depressor you can take just washing. After washing any still tongue depressor you can take tongue depressor. So you can check by using these 2 things. In the mouth cavity and nose, just for the general examination. Detailed examination, you need to see the retina. Then you need to take the fundoscope or ophthalmoscope, and you need to check the otoscope, and then you need to see the nasal speculum. You need to see the interior of the nose. Other thing you need to do. So you can tell the patient to open the mouth. See, use of this thing. Use of this thing is very important. Don't gossip. See, just move to that side so they can also see. So the examining the face, you need to tell the patient to open his mouth, and need to tell the patient not to move his tongue like this way. Is that clear? If the patient move his tongue outside like this way, and you put this tongue depressor like this way, then your tongue depressor will press the tongue over the teeth of the patient. That will cause injury to the tongue. So what you need to tell the patient? Don't move out your tongue. Just open the mouth. Don't move out the tongue. Just okay. Your tongue should be inside. And open your mouth clearly.
Borogar.
Don't turn forward, but up to this one. Okay. So you need to pull like this way. Pull like this way, and then put the torch there. And see at first, see this area, and then this area, and then downside. And is there any swelling of any that the gum or not? You need to check upside. You need to check there any rash or not. You need to check, and then you need to check the interior. Is there any? Don't move your tongue. Just step and relax. Relax your tongue very easily. So it is very tough. You need to check like this way. Put the tongue. You need to remember this one. Tongue depressor. Don't place tongue depressor to the posterior aspect of the tongue. It will cause gag reflex. Patient will vomit on you. So don't place this one. Just place like this way. Tongue need to be inside your teeth. Inside your teeth. Okay. And then this one you need to put. No, easy. See, I can see interior of the tongue, interior of the that one move more and say yeah, like this way. I can see the tonsil also. I can see the both tonsil and other thing also. Upside and tell yeah. I can see the tonsil, both side tonsil and other thing also I can see. Clear? So this is enough to check the mouth cavity. It's enough to check the mouth cavity. And then we need to check the nose. We know the nasal cavity, the direction of nasal cavity is horizontally backward. It is not upward like this way. It is not upward like this way. It is horizontally backward. So nasal cavity you can check like this way. Just put your hand, put your fingers on the forehead, and then put your thumb onto the tip of the nose and move the nose outside, and then put this light onto there, and you can see the interior of the nose clearly. Is there any obstruction? Is there any swelling? Or initially you can check that nose, clear cut. And then you need to see the air. I told the external air is S-shaped. External air is S-shaped. So it is from at first the direction is forward. To pull the patient's air to outside and outward. Then the external air will be straightened. External air will be straightened like this way. Like this way you can check. Just upside, and then put the torch. Upside and outside. Then you can see the air drum also. You can see the air drum also. You can see the air drum also like this way. So you can put the air to the upside and outside, and then you can see the air drum also. Clearly you can see the air drum. Clear? So mouth cavity, nose, air we have checked. And now we need to check the eye movement. Normally we do only one consensual light reflex. Consensual light reflex. That is, you need to open the eye and then tell the patient to see towards you, and you need to check, you need to see the pupil. You need to see the pupil, and then you need to put the light from outside to inside slowly. When you fall the light onto the pupil will constrict. Pupil will constrict. So there is a pupillary constriction is there. You have checked. Is that clear? You need to check other something also, whether it will help you for further investigation. Like this way, the patient can move all the joints of the superior limbs or not. You need to check. You need to check. You can tell the patient to move his hand or the joints. Is there any pain or moving during moving, or this is called active moving, and then you need to check the passive moving. You can move, and then the patient is feeling pain or not. That shoulder joint, and then elbow joint, and then wrist joint. You need to check like the flexion, extension, all the joints. You need to check. You need to check whether is there any swelling in the joint. Is there anything happened in the joint? Feeling pain, active motion, passive motion, you can check. And also you can check the muscle condition. Muscle condition, that is the strength of the muscle, tone of the muscle, also you can check. The strength of the muscle, you can tell the patient to pull your hand muscle is okay. Strength of the muscle is okay. And this is the flexion. Flexion. And then you need to tell the patient to push me. Push me. Yeah. So extensor muscles are okay. Extensor muscles are okay. Extensor muscles are okay. So muscle strength and other thing we have checked in this front position. Is that clear? Is that clear? Then you need to check the pulse. At first you need to check the carotid pulse. Carotid, just put 3 fingers onto the medial margin of the sternocleidomastoid muscle. Medial margin of the sternocleidomastoid muscle. And press your three finger against the trachea. And then press downside. So you will form the carotid pulse. I have found it. At first you need to check what? You need to find the medial border of the sternocleidomastoid and then press it into the trachea and then push below. Is that clear? So you can find the pulse or carotid pulse. You need to check the carotid pulse like this way. 1 minute or 15 seconds. You can check the for 15 seconds, then you can multiply it with 4. In carotid pulse, we should not press it for long time. Jugular venous pressure, we cannot check in this sitting position. Jugular venous pressure we can see from the lying position, supine position in 45-degree angle. 45-degree angle we can check the jugular venous pressure. Then carotid pulse when you check, and then you need to check the radial pulse. So radial pulse when you are checking, you need to check like this way. Don't forget to see your watch. So you need to count. You can count the radial pulse rate. So you need to check the pulse rate like this way. 3 fingers you can put, and you know why we are putting this way. And by which finger we are feeling the pulse mainly. That is middle finger. And then we need to check the carotid pulse, whether it is present or not, whether the rate is there or volume is there, is okay, character is okay, and then rate is okay, rhythm is okay, you need to check. That is the pulse, radial pulse. Manometer. See the sphygmomanometer. This sphygmomanometer has 2 things. One is the meter, one is the pumper, and this 2 is placed here. You need to take the sphygmomanometer in your hand like this way. Right hand this 2. Remember this thing. Right hand this 2, and left hand this 2, and this thing facing you. This attachment thing facing towards you, and then place this right hand thing onto the arm, and this rubber tube, this should be placed in the middle. Clear. Remember this thing. Otherwise you will put this one and then you move this, then that thing. That will not cause the pressure onto the artery. So you need to remember this one to the right hand, and then this one into the left hand, and this one towards facing your mouth, and then place onto the arm like this way. This one in the middle, better in the middle, and then you need to place the calf onto the arm, and then you can place 1 finger inside here. You can place 1 finger inside here. You can try. Yes, that is. We can press the 1 finger. Place the 1 finger inside. If you can place 2 fingers, that is wrong. Or if you cannot place 1 finger, that is also wrong. So it is very easy to determine. Just place, and firm pressure this end onto the arm, and then put easily onto there. So 1 finger will be there. 1 finger you can put inside there. Here. And then it should no problem. And then this is the meter. This can be clipped like this way. There is a clip. present. And there is one attachment knob also there. So you can place this one. You can place this one like this way. Here. This is a clip. So you can put the clip here. Don't put the clip like this way. So when you can press, then this clip will press onto the hand. It will create some problem. the patient will feel pain. So you need to remember, just in this paper, you just clip it and put it like this way. Clear. And then you need to check. You need to check whether this is in zero or not. It is better if the position of the heart and this meter is in same. It is better during checking. And then you need to place your stethoscope. Before placing a stethoscope, another thing also, there is the systolic blood pressure. Systolic blood pressure you can check by manual way. So you need to check how you can check this manual way. You need to check the pulse at first, whether there is pulse or not, and then increase the pressure. Increase the pressure slowly, not too much. You can up to 200. You can move up to 200. Then you need to release the pressure very slowly. Then you will, when pulse is appear, so it is systolic pressure. Diastolic pressure cannot be checked manually without a stethoscope. Diastolic pressure cannot be checked. This is the systolic pressure. And then diastolic pressure, you need to put your stethoscope and check it is working or not. You need to check. And placing the stethoscope should be forward. This too should be, earpiece should be forward. You need to check whether it is okay or not. And then you need to place it. And then you need to check whether it is in diaphragm side or not. And then you need to put this onto the brachial artery. And it is placed just medial to the hand, medial side of the hand. You need to put it there. Medial side of the hand, not in the middle. It is medial. Just into the medial, slightly medial to the hand, slightly medial to the hand. You need to check. And then you need to increase the pressure. During increasing the pressure, you need to see the meter. When you are increasing the pressure, you need to see the pressure. And then you need to put it up to 200 or like this. Then you need to release the pressure slowly. So at the moment, you will found the beat. The starting beat, when it is appeared in your stethoscope, you heard, that is the systolic pressure. Yes, I am founding beat now. And then this beat will disappear at a certain pressure. Yes, it is disappeared. That is 80. So his pressure is 120 by 80. Systolic pressure, when the beat is appeared, that is systolic pressure. And then when the beat is disappeared, that is diastolic pressure. When means at which pressure the beat is appeared and at which pressure the beat is disappeared. That is diastolic pressure. So you need to write that systolic pressure is this one and diastolic pressure is that one. So this is the way of taking the pressure. You need to check the breathing rate also from the front. The checking breathing rate is very critical thing. You should not allow him or patient that you are checking the breathing rate, as because patient can control the breathing rate himself. So you need to check the breathing rate per minute in minute without notice that I am checking the breathing rate. Is that clear? So the patient should not aware of that you are checking the breathing rate. Normal breathing rate in adult, that is the 18 beat per minute. You need to check. And then you need to check the patient from backside. From backside examination, you can check like this way. That is, you can stand in the right side of the patient. You can come here. You can stand from the right side of the patient. You can check the patient from the right side in the back, or you can stand from the back to check the back side. First you need to inspect. Whether there is any swelling, whether there is any deformity like this way. Patient cannot stand clearly like this way, or there is any scoliosis. The spine is moved like this way, or you need to check is there any kyphosis or lordotic change. This is the kyphotic, this is the kyphosis, and this is lordotic. So this curve is like lordotic curve is okay, and this is kyphotic curve. So this is more kyphotic, maybe problematic, more lordotic, maybe problematic. That is why. So you need to check, you need to investigate. There is any pigmentation, there is any scar mark, if there is any other deformity, if there is any pigmentation or any other thing, you need to check. Any swelling, any injury or any kind of open wound, you need to check. You need to check the hairstyle or hair distribution also. You need to check the hair distribution also. And then you need to check from the back. You need to check the motion of the neck motion. Very important thing. The neck motion, you can move the neck from right side to left side. Move your head like this way and this way. So it is okay. The motion is quite normal. And then you need to check the chest. Before checking the chest, you need to examine the lymph node of that is cervical lymph node and the submental submandibular head. See this one. The procedure of checking the cervical lymph node and occipital lymph node is like this way. Some books written that you need to start checking from here. This is the occipital lymph node. This is the occipital lymph node. You need to check it. And then go to the post-auricular lymph node. Post-auricular lymph node. And then go to the pre-auricular lymph node. And then go to the submental lymph node. And then submandibular lymph node. Submandibular. And then what? Anterior cervical and posterior cervical. Anterior cervical and posterior cervical. All these lymph nodes you need to check like this way. Some tell that you start from mental, submental, and then submandibular, then anterior, posterior, and then preauricular, postauricular, and then occipital. We can check. But as we are starting from the posterior side, we can start from this way also. Just take this one, and then posterior auricular, and then preauricular, and then the submental palpation, and then palpation. In the palpation, what you need to do at first? That is expansion of the chest wall. Expansion of the chest wall. It is very easy. See the note. The expansion of the chest wall. You need to put your finger in the lower aspect of the chest, and then move your finger towards the middle and confirm that this skin is folded like this way. Is that clear? And then tell the patient to breathe deep breath please. Yeah, it is expanded. And then again deep breath. It is expanded. Normal expansion is 5 to 8 centimeter. In between your finger, that is 5 to 8 centimeter. This is called chest expansion test. Chest expansion. So line along the mid-scapular line. This is the scapula, and this is the midpoint of the lower order of the scapula. This is the mid-scapular line, and this is called mid-scapular line. This is the mid-scapular line. You need to place your right hand like this way and this way, 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 and serially like this way. But when you are placing your hand, you need to check whether it is in the intercostal space or into the rib. You need to check on the rib and then on the rib. Intercostal space, like this way, like this way. This is called vocal fremitus test. But when you are placing this hand, you need to tell the patient to tell 11 or 99. Loudly.
99.
So you are feeling, I am feeling some vibration. That is called vocal fremitus. Percussion in the backside, two lines. This is the mid-scapular line and in the mid-axillary line. In the mid-axillary line, you need to check. And percussion start from the apical region. This is the apical region. You need to percuss and compare with both sides. And when you percuss onto the scapula, don't need to place your finger here. In the apical, you need to scapula, of the scapula, you need not to press. You just press your finger like this way. Is there any other sound except resonant sound? And then from the below to the scapula and onto the mid scapular line, you need to put. Just stop, and you can hear the sound. Stop talking. And then compare in both sides. Or you can do like this way. This side and this side. 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 Like this way. Up to lower border of the chest cavity or chest. Up to lower border of the chest. You feel the ribs. Up to rib where you found the ribs. So you need to remember percussion. You need to way of percussion you know. That is, you need to place your middle finger here, and then you need to move your hand not like this way, not like this way. Your elbow joint should not be moved. Your elbow joint should not be moved. Only wrist will move. Only wrist will move. Only wrist will move. Only wrist will move. Like this way you need to check, and then you need to check the mid axillary line. Put your hand like this, and then you need to check the mid axillary line. In the mid axillary line, and then compare to opposite side also. Is that clear? This is the percussion and palpation, and then percussion, and then you need to do the auscultation. You need to auscultate from the posterior aspect of the chest. If you auscultate, you start from here and take breath. Tell the patient to take breath, and then you need to check apical region. Take deep breath. Yeah, and then you need to check from here. Take deep breath. I am going towards what? Mid scapular line. Deep breath. And then you need to check mid axillary line. Deep breath. You need to check here from. Deep breath. In auscultation, what we need to see from here? From back, we need to see. We do not need to check the precordium from back. We are checking lung field. In the lung field, we can find what sound? That is in this area. In the mid scapular and mid axillary line, all time we will find the bronchial or vesicular. Which one? Vesicular breath sound. All time we will find the vesicular breath sound. Vesicular breath sound. What is the criteria of vesicular breath sound? Normal vesicular breath sound. Vesicular breath sound. Normally we will find the vesicular breath sound. That is, inspiration is long and expiration is short. And there is no gap in between the inspiration and expiration. There is no gap in between the inspiration and expiration. And bronchial breath sound. Bronchial breath sound we found in mainly into the trachea bronchus center. There is a bronchial breath sound. And this bronchial breath sound will be what type? Bronchial breath sound, there is gap in between inspiration and expiration, and timing of inspiration and expiration are same. And there is gap in between the inspiration and expiration. That is called bronchial breath sound. If I found any bronchial breath sound here, I am finding any bronchial breath sound in the periphery, not into the neck or not into the center of the chest. Then what indicates? It indicates there is some problem in the lung field. It may be consolidation, it may be fibrosis, it may be other problems is there. So I am finding some bronchial breath sound here. That is the thing. And then sometimes we need to think about added sound. What are the added sound we found in the chest wall? Number one, that is bronchi or crepitation. Bronchi, that is musical sound, like a fluid like a flute. Musical sound. It commonly we found in case of bronchial asthma. Like this. That is a bronchial asthma patient. There is a fine that is called ronchi sound or whiz sound. This is called ronchi and whiz sound. And then wait, another one is the crepitation. Crepitation, there is crackle sound, crackle. And this crepitation sound we can found in case of left ventricular failure also. Fine clefts we can found in the basal side. Basal side we can found. And sometimes other crepitation also found. You need to read the causes. Crepitation, what are the causes of crepitation? Fine crepitation course, it is in the note, you can see. And then what are the causes of the specific ronchi? What are the causes of ronchi? What are the causes of crepitation? We need to see. So from the back, we can check like this way and then tell the patient to lie down onto the bed and supine position. Normal system to open or to expose the patient up to mid-thigh level. So we can check the we examine the genitalia also. And in case of female, you need to check whether there is attendance or not. Several times I am telling. In case of male, should not be or no need. But you need to take the consent from the patient. So at least you can open up to the spine. Otherwise I cannot check the abdomen. Don't feel shy. This is quite dangerous. I will not expose. So I can examine. See. At least this one you need to expose. At least this one. At least up to this. So you can see the top margin of the symphysis pubis. You can see the top margin of the symphysis pubis, and you can see the hair distribution also from here. Hair distribution, that is the triangular shape in male. You need to inspect. Take the visible pulsation onto the neck, visible pulsation onto the chest, and any visible movement onto the abdomen. And then you need to check any kind of swelling onto the abdomen, any kind of swelling onto the chest, any kind of deformity of the chest, any kind of scar mark, any kind of pigmentation, any kind of thing you need to check at first. You already have checked this one in sitting position also. In lying position, mainly we check the pulsation. Any pulsation, abdominal pulsation is there or not, you need to check. And then you need to check the JVP. You need to remember JVP, when you are checking the JVP or jugular venous pressure, you need to pull the patient up to 45 degree. How you can measure the 45 degree? Angle? At first you need to think, this is the 90 degree angle. This is the 90 degree angle with the bed. This is the 90 degree angle. You can measure, simply you can test. You can check, this is the 90 degree angle with the bed. With the bed, this is the 90 degree. So in the middle of this position, you can move the head up to this. Yes. Okay. Relax. Easily. Just move your hand, move your chest onto my hand. Yeah. Relax. Onto my hand. Yeah. And then you need to check. Check any jugular venous pressure. If you found the jugular venous pressure here, jugular vein, palpable jugular vein, you need not to place your hand. You need to remember the mainly when you are checking the arterial pulse, that is the carotid pulse, you need to feel the pulse. But the venous pulse, that is the jugular venous pulse, you need to see. You need not to feel. Jugular venous pulse, you need to see. And normally it cannot be seen. But if you see, then the midpoint of the pulsation, such as pulsation is, this pulsation is like this way, larger. So midpoint of the pulsation you need to take. Midpoint of the pulsation you need to take. So in this position, midpoint of the pulsation, you need to take one imaginary line and then one imaginary line in this level here. This is the vertical line, and this is the horizontal line from this. And when you touch this horizontal line in this measurement, such as his one is this one, in centimeter, you will find the pressure of the jugular vein or jugular venous pressure in centimeter. If you count this one,
So
this is the pressure. This is the pressure. Is that clear? Is that clear? That is the jugular venous pressure. And then now we need to check the we need to check the pulse. Now we need to check the pulse and blood pressure again in lying position. Sitting position blood pressure you need to check. Lying position blood pressure you need to check. Sometimes standing position blood pressure also need to check. So in lying position you can check the blood pressure also. If you check the blood pressure in right hand, in the sitting position also you can check the pressure in right hand or in the left hand also. But as I am checking from the right side, so I can check it from right side or right hand. That is the blood pressure. And pulse. In case of pulse, we need to check the carotid pulse also from here. And this during carotid pulse, checking the carotid pulse, you need to count it and you need to check it. And 15 seconds is enough. Then you can multiply it with 4. Then 1 minute pulsation you can check. You can find. Then you can check the brachial pulse. It is found in the medial side. You can count. Just press here and then medial side you can feel the pulse. There is the brachial pulse. And then you need to check the radial pulse. The examination of radial pulse from the right side is handshake with the patient and then put your left hand onto the pulse. That is the radial pulse. In this finger you need to fix, and then this one you need to feel. This one adjust. The index finger for fixing the blood or moving of blood you can fix, and then you can feel the pulse by this finger, and then you need to adjust the pressure with this finger, and then you need to check what? You need to check wall of the artery. You need to check the rhythm. You need to check the rate. You need to check the volume. All you need to check in the arterial pulse, and also you need to check the radiofemoral delay. During checking this pulse, you need to check the pulse of the femoral artery. Femoral arterial pulse you can check here. Just midpoint of the from. No, don't feel shy. You are male. You are not female. This is the anterior superior iliac spine. This is the anterior superior iliac spine, and this is the tip of the symphysis pubis. Just easy. This is symphysis pubis, and then this is the midpoint. Midpoint you can just in the midpoint, just below the midpoint you can find the femoral arterial pulse. You will find the femoral arterial pulse. Yes, I am finding. This is the femoral arterial pulse. So you need to check arterial pulse and femoral arterial pulse, whether it is coincide with each other or not, or is there any delay. The neck. So in the neck, at first we need to check the trachea. How we need to check the trachea? These three finger we need to use. These two finger put these two clavicular end, and then middle finger you need to fix it onto the trachea, and then press below. Don't press much, then you will feel suffocation. So you can feel whether it is here or there, or it is in central position. It should be in central position. You need to check it whether it is a central position or not. You can move your middle finger from here and there, and you need to check it like this way, whether it is middle position or not, or whether it is moved to right side or left side. What is the causes of shifting of the trachea towards the problem? What? Such as collapse. And then what are the thing pushes the trachea to opposite side? Diffusion, like this way. And then palpation of the chest from anteriorly. Palpation of the chest. What are the thing I need to palpate? There is a palpation of the chest from the anterior side. The trachea I have palpated, and then next palpation, what we need to palpate? That is local temperature. At first you need to check the local temperature. At first you need to check the local temperature by placing your dorsum of the hand onto the body, local temperature, and then tenderness. You need to check any tenderness onto the body by palpating very slowly. Very slowly you need to palpate. Is there any tenderness or anything is there? And then you need to check, you need to palpate the apex beat. The apex beat palpation is very much important. How you can measure the fifth intercostal space? Which one is the fifth intercostal space? At first you need to find one prominent area into the chest. Prominent area and onto the chest. That prominent area is the second intercostal. Second rib will attach with that prominent margin. That is called mandibulosternal angle. In this mandibulosternal angle, this is the second rib attached. Then from the second rib, you need to count third rib, fourth rib, and then fifth rib. And then what is the intercostal space? First and second, that is first. Second and third, that is second. Third and fourth, that is fourth. Then fourth and fifth, that is fifth intercostal space. Fifth and sixth. In between fifth and sixth, that is fifth intercostal space. If it is the fifth intercostal space, you need to palpate the heartbeat, that is apex beat, from middle to here or here to here in the fifth intercostal space. Or we, in case of male, we just can put the finger just below the nipple in the mid clavicular line. You will find the normal apex beat. I am finding now. Or you can check like this way also, in the mid intercostal space, fifth intercostal space, from middle to the left. From middle to the left. It may be shifted to the left sometimes also. Or you can put just below the nipple. That is the fifth intercostal space. You can find the apex beat. That is the palpation. And then thrill. You need to check the thrill. The thrill that can be palpated due to the any kind of problems occur into the heart valves or septal defect. That is due to the, if we found any murmur in the stethoscope, if that murmur or abnormal sound of the heart can be felt by hand, those are called thrill. In some stages of the murmur, that is, murmur stages starts from first stage to the sixth stage. Normally, from third stage of the murmur, we can feel the thrill from the heart. And then you need to feel where? Thrill you need to feel from the apex area, and then tricuspid area, and then this is in the left side, it is pulmonary or aortic? Pulmonary area, and then aortic area. In the second intercostal space, or second intercostal space in the left side and right side. Left side you will find the pulmonary area and aortic area. And when you palpate all these things, and then you need to check the axilla also. Is there any thrill present in the axilla? Is there any thrill in the neck? You need to check. And this is the way of checking the thrill or palpating. So at first you palpate the chest and then expansion of the chest. Yeah, 3 fingers or full hand you can use like this way, and like this way. Thrill you can feel. The thirsting appearance into your finger. Yeah, palm of the finger. And then expansion of the chest, I have explained in the back side also. You need to check in from the anterior side also. You need to check. This is the expansion. You need to think when you press, this skin should be folded in the middle. The skin should be folded. If the skin will not fold like this way, it is not clearly, you are not clearly expanding this one. So you need to pull like this way, and this one should be like this. And then you need to tell the patient to breathe deep. Don't facing me, facing that side. You need to take breath with mouth open, and take deep breath, and normal expansion is 5 to 8 centimeter. Normal expansion. Sometimes one side may be less expanded or one side may be more expanded like this way. This is expanded but this is not expanded. If the finger is moved this one but this is not moving, it means this wall is not expanding. This wall is not expanding. So when it is not expanding or less expanding, such as it is expand like this way but it is expand less. So expand unilateral expansion release or unilateral expansion is less, you need to check, or both side expansion is less. Sometimes in bronchial asthma, in diffuse fibrosis, this both side will be less, expansion will be less. It is severe condition. So then we need to check the vocal freemitas from the anterior side. Vocal freemitas, not the vocal resonance. Vocal resonance we need to check with stethoscope, and vocal freemitas we can check from the hand. So you need to tell the patient to tell or to 99 and then
99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
Yeah. So you need to check both sides in the mid scapular line or mid clavicular line. Mid clavicular line you need to check. This is called vocal freemitas. When vocal freemitas increase, well decrease, you need to see the note, and then we need to check we need to percuss the chest. Percussion should be started from the apical region. This is the apical region, and you need to percuss. You need to percuss like this way. When you percuss, you need to check both sides, and then first intercostal space, both sides. When you are pressing finger, you need to check it is deep or not. It is deep means it is in intercostal space, and then you need to check like this way, and then opposite side you need to check, and then opposite side you need to check. So see this is resonant. This is resonant. So you can compare which one is dull sound, which one is resonant sound. Which one is resonant sound, which one is dull sound. Or you can switch off the fan, then you can understand this sound also. This one is resonant sound. This one is resonant sound. This is resonant sound. This is dull sound. This is resonant sound. This is dull sound. This is resonant sound. This is dull sound. You can compare. Sometimes lung field also we can find the dull sound. When stony dull, pleural effusion. Also we need to find the upper margin of the liver. We need to count the upper margin of the liver. You need to count how you need to percuss from second rib or second intercostal space, and then you found the dull sound. That is the upper border of the liver. That is the upper margin of the liver, and then you need to see from easy. This is the lower margin or that is the costal margin, and from this costal margin you need to check. This is dull. So this is the range of the liver. So this liver boundary you need to measure like this way. Liver boundary in the mid clavicular line you need to percuss. When you found the dull sound, there is the upper margin of the liver, and then from the here, just below the intercostal space you can find. You can check, and then you found the liver. Sometimes you can find the liver. Otherwise, normally below the this margin you will not find any liver. If liver enlarged, then you need to measure from the lower margin of the this costal margin. From the lower part of the costal margin, you need to count what inches it is increased in size. If normally it is, if there is, the liver will not be palpated or cannot be palpated from this area. From the abdomen, it is not palpable. It is not palpable. If there is any pathology, it is palpable. And then you need to check the what is the length of here from the there is the margin to the here, and then we need to palpate. Then we need to start the auscultation. in the auscultation, what we need to do? At first we need to check the lung field, and then we need to check the precordium. At first we need to check the lung field, then the precordium, and then we can check for the vocal resonance. Vocal resonance. Vocal frequency cannot be checked with the stethoscope. So you need to check the stethoscope and then put. Sometimes I found it. This type of doctor also put the stethoscope here and then check. See the thing. So you need to put the stethoscope in your ear at least. Otherwise, how you can understand the sound? and then you need to check. You need to tell the patient's mouth to against you. So his breath will not disturb you, or sound will not disturb you, like this. And so you need to check. You need to check the thing from apex also. You can tell the patient to deep breath, take deep breath. Yes, deep breath, and take deep breath, and then towards the mid-clavicular line you need to check. On the mid-clavicular line you can check like this way, and then you can check from here also on the mid-clavicular line. Both sides you can check, and then you can check from like this way also, from apex, and then this side, and then this side, or this side, and then this side. You can check like this way also, comparing. But you must need to check both sides in the mid-clavicular line. Then you need to check the mid-axillary line. From this side, you need to check the mid-axillary line. Along the mid-axillary line from up to down, you need to check the breath sound. I am checking now breath sound and any kind of added sound in the lung field. Breathing sound, normal breathing sound we found in this area. Those are vesicular sounds. Vesicular sound is in between vesicular inspiration expiration. There will be no gap. That is the important findings. There will be no gap in between inspiration and expiration. Prolonged inspiration, less expiration, it is very difficult to count. But there is no gap in between inspiration and expiration. That is very easy to understand. So you can understand this is vesicular breath sound. If you found any bronchial breath sound, then you need to check where. Normally bronchial breath sound we found here. We can found there is gap in between inspiration and expiration, and both are same. Both are same in length. That is called bronchial breath sound. Sometimes bronchial breath sound also you found in center also on the trachea. On the trachea you will find the bronchial breath sound. This is normal. But if you found the bronchial breath sound in the chest field, then it is abnormal. And also you need to say the added sound. Is there any rhonchi? You need to think bronchi means one kind of musical sound, and the crepitation means crackle sound you can find. So these are the thing you need to check in auscultation. And then next, then we need to check the precordium. Precordium means only cardiac side we need to check. Precordium examination, when you are examining the precordium, at first the patient should be in supine position. In this position, you need to check the apex beat first. Lap tap, like this. Okay, I'm found it. And also you need to check the tricuspid area. You found in the left margin of the sternum. In the fifth intercostal space, or you can find in the just lower side of the left margin of the sternum. You will find the tricuspid area. This is mitral area, apex beat. This is tricuspid area. And then you can go to pulmonary area. Normally pulmonary artery arises from right side, aorta arises from left side. But in here we found in the left side we found the pulmonary. But pulmonary artery arises from where? From the right ventricle, and aorta arises from the left ventricle. But you will not find the aortic area in the left side. You will find the pulmonary area in the left side, and that is in the second intercostal space, just beside the sternum. Second intercostal or menuprium. And then here in the right side you will find the
aortic area. So you will found the beat also, lambda beat all you will found normal. If you found no other added sound, no other murmur or no other sound other than the first sound and second third sound, that is okay. That is normal. The precordium is normal. But if you found any murmur, then what you need to think at first you need to think it is systolic or diastolic. It is systolic or diastolic, and also and then you need to check the S1, S2 again by placing your left hand onto the carotid artery. Which one is systolic sound, which one is diastolic sound, you need to differentiate. How it will do? At first you need to check there is any beat or not. Yes, there is beat. So systolic and diastolic. You need to check which one is systolic, which one is diastolic. How you can check which one is systolic? And there is lambda beat is there. So beat, you are understanding the beat. Yes, and then you need to place the left hand onto the carotid arterial pulse. Carotid arterial pulse anterior to the that sternocleidomastoid muscle, middle, and then press onto the trachea and then deep. You will find the carotid arterial pulse. Yeah. So it is coincide with one beat. That is the systolic beat. That is systolic beat. Then if murmur is there, then you need to check the murmur is coincide with systolic beat or diastolic beat. Then you need to think it is systolic murmur or diastolic murmur. So systolic murmur, you need to fix your finger onto the carotid arterial pulse. Carotid arterial pulse, normally you need to press deep. You need to press like this way. You need to press in the that is anterior border of the sternocleidomastoid, mid position. Then press your finger onto the trachea, then deep. Then you'll find the carotid arterial pulse. Then you need to find that murmur sound. If it is coincide with the carotid arterial pulse, it is systolic murmur. If it is not coincide with the systolic, then it is diastolic murmur. Clear? And murmur, when you found the murmur, there are mainly systolic murmur and diastolic murmur. Systolic murmurs are the pansystolic murmur and ejection systolic murmur, most commonly we found. And then diastolic murmur, mid-diastolic murmur and early diastolic murmur we found. These two. Sometimes we found the continuous murmur, PDA, that is patent ductus arteriosus. That is continuous murmur. And you need to remember the stenosis and regurgitation. Valvular problem. Remember this thing. You will not find this thing in any books. These are the techniques, our techniques to find out the systolic murmur and diastolic murmur. Very important things. See, when you found that this is the systolic murmur, that you need to think which area I found this murmur. If it is in the mitral area, it may be due to the mitral valvular problem. If it is into the tricuspid area, it may be due to the tricuspid valvular problem. Stenosed valve cannot open clearly. It is stenosed. It can close clearly, but stenosed valve cannot open clearly. But regurgitated valve cannot close clearly, properly. So it will remain open during when it need to be closed also. So stenosed valve cannot open clearly. So remember this thing, when the ventricle is contracted, aortic valve and pulmonary valve need to be open. So if it is a stenosed valve, it cannot open clearly. So it will causes the obstacles of the blood flow. That obstacles of the blood flow causing the murmur, that is called systolic murmur. So aortic stenosis, pulmonary stenosis causes systolic murmur, as because the valve cannot open clearly. Aortic stenosis and pulmonary stenosis causes systolic murmur. And the regurgitated valve, such as when it is systole, it is clearly open, but regurgitated. When it is diastolic phase, the atrial valve and the pulmonary valve need to be closed. Tricuspid and bicuspid valve need to be open, need to be closed, but at that time that cannot be closed clearly. Some blood is regurgitated to the back. some blood regurgitated to the back. That is regurgitate valve. Regurgitate valve cannot be closed clearly. Cannot be closed clearly. It should be closed during diastole, but it cannot close. So some blood is regurgitated into the back flow. So that causes the murmur. When this blood is flowing, regurgitate valve into the aortic valve and the pulmonary valve, that causes the diastolic murmur. So remember, aortic stenosis, pulmonary stenosis causes systolic murmur. Aortic regurgitation, pulmonary regurgitation causes diastolic murmur. And now come to the to mitral valve and the tricuspid valve. Mitral valve, when opens, during diastole or during systole? During systole, blood need to be go to aorta and pulmonary artery. So it need to be closed during systole. It need to be closed during systole. So the tricuspid valve and bicuspid valve need to be closed during systole. So during systolic phase, if there is any problem due to the closure of valve, it means it cannot close clearly. During systolic phase of the heart, this valve need to be closed. During systole, it need to be closed. And as it cannot be closed clearly when regurgitation or stenosis. Regurgitation. So some blood will pass back. So it will cause systolic murmur. So bicuspid valve and tricuspid valve causes systolic murmur when those are regurgitated. When the valves are regurgitated, that causes systolic murmur. But aortic valve and pulmonary valve, when they are regurgitated, they cause diastolic murmur. Opposite. This causes systolic murmur when regurgitated. There is tricuspid and bicuspid. Tricuspid and bicuspid, if stenosed, during the diastolic phase, this tricuspid and bicuspid valve need to open. It cannot open clearly if stenosed. So it causes some murmur. Diastolic phase, so it will produce the diastolic murmur. So in case of that stenosed tricuspid valve, the stenosed bicuspid valve, most commonly happen bicuspid stenosis, mitral stenosis. That causes the diastolic murmur. And remember this thing, when you found the diastolic murmur is there in the mitral area, check the mid-diastolic murmur. Mid-diastolic murmur occur in which case? Mitral stenosis, most commonly. That is mid-diastolic murmur. To check the mid-diastolic murmur, we need to tell what? That is left lateral position. The patient should be left lateral position, and then we need to check by bell of the stethoscope. When? Then the breath need to be held after expiration. And with the help of bell, we can check the mid-diastolic murmur. You need to check this murmur by placing the patient left lateral position, and knee flexed, and with the bell of the stethoscope. Just put it here. Then there is no sound. There is some sound. With the bell of the stethoscope, and tell the patient to breathe held after expiration. After expiration, you need to tell the patient, do this thing. Then hold. Like this, okay? And then you need to check with the bell of the stethoscope on early diastolic murmur in the third intercostal space in the left border of the sternum. And we found this early diastolic murmur in this position, that is in the aortic regurgitation. So and then another special area you need to check, that is called the second aortic area. This second aortic area lies in the third intercostal space. You can measure, I have told how you can measure the second and third intercostal space. In the third intercostal space, in the left side of the manubrium. In the left side, second intercostal space, you found pulmonary area. third intercostal space you will find the second aortic area. The importance of second aortic area is you can find the VSD, murmur of the VSD, that is ventricular septal defect. This ventricular septal defect we found the mainly pansystolic murmur. We also can find this pansystolic murmur in case of bicuspid regurgitation also. Bicuspid regurgitation also we found the pansystolic murmur. If we found the pansystolic murmur in bicuspid regurgitation, that pansystolic murmur also can be radiated to the axilla. But if we found the pansystolic murmur in the VSD in third intercostal space in the left side, left border of the sternum, then it indicates it may be VSD and it is not radiated to the axilla. If you found any VSD, that is the pansystolic murmur in the second aortic area, that is the third intercostal space, that is in the third intercostal space in the left side of the sternum, that is pansystolic murmur. If you found any murmur, and this pansystolic murmur if not radiated to the axilla, that is VSD or ventricular septal defect. Another murmur also we can see in this second aortic area. Another murmur also we can see, that is the early diastolic murmur. That is early diastolic murmur. This early diastolic murmur we can find in the aortic regurgitation. In case of aortic regurgitation, we can find the early diastolic murmur. This early diastolic murmur we can find in the aortic area also, and also we can find in the we can auscultate in the third intercostal space in the left side, that is called second aortic area. Second aortic area. This is not second aortic valve. Someone asked me like this, second aortic valve. It is not second aortic valve. This is the second aortic area. This is second aortic area in the third intercostal space of the left border of the sternum. Like this way, if we found any early diastolic murmur, that early diastolic murmur you need to check by sitting position. By sitting position and leaning forward like this way, leaning forward, be easy and leaning forward and tell the patient to expire and then hold the breath, just expire and then hold the breath, and then you can check the which area, that second aortic area. If you found early diastolic murmur in the second aortic area, early diastolic murmur position is sitting position, leaning forward, and you need to check with the diaphragm of the stethoscope, and patient need to be hold the breath after expiration. Then you can expose the patient up to the mid-thigh level. It is compulsory for the abdomen examination. But as we are practicing here, and there is no privacy in this room, and so we do not want to hamper our student. Okay, that's why we expose up to upper margin of the symphysis pubis only. And then we can examine the abdomen. Before examining the abdomen, you need to know what are the regions of the abdomen. This is a normal thing.
Nothing.
Normal. So this is the upper margin of the symphysis pubis. Up to this, sometimes we also we need It's okay. Don't laugh. So he will feel embarrassed. Okay, don't laugh.
Nobody will do this. So
Don't laugh.
কেউ করবে না এটা, তুমি করবে না, করতেছি।
Exposure is the main thing. I am telling you. Some patients have a large swelling in the scrotum. Large swelling. It may be hernia. It may be hydrocele. He will not tell you. He will not. You examine the abdomen. You did not expose the genitalia, and he did not tell there is a swelling. And then teacher will come and teacher exposed and found one large swelling there. And you told to the teacher there is nothing found, nothing I found in the abdomen. And teacher will say this one is swelling is present in the scrotum. So you need to remember that is the normal procedure of examining the abdomen is you need to expose the patient up to the mid-thigh level. With privacy you need to do that one, and so we can check the genitalia also. And then before examining the abdomen, we need to know how we can subdivide this abdominal area into 9 regions. Very simply we can do this one. You can just draw one imaginary line in the mid-clavicular. This is the mid-clavicular line. Another mid-clavicular line. That is 2 mid-clavicular line. One is the left mid-clavicular line. Another one is the right mid-clavicular line. And then this, after pointing these 2 lines, then another 2 lines you need to draw. One is the transtubercular line. One is the transtubercular line. Another one is the transpyloric line. Another one is the transtubercular line, and this is one is the transpyloric line. Transpyloric line. So remember this thing, transpyloric line you found in the top tip of the symphysis pubis, from the tip of the symphysis pubis to the jugular notch. Midpoint of this area, don't talk. Don't talk. Yeah, let me talk. So this is the jugular notch. This is the jugular notch, and this is the tip of the symphysis pubis, up margin of the top margin of the symphysis pubis, and then you need to measure the half of this area. Half of this area you can measure by this hand. So this one, and then this portion half. So this is the transpyloric line. The transpyloric line, or you can say this is the subcostal line. This transpyloric line or subcostal line, and transtubercular line. The top margin of the hip bone. Top margin of the hip bone. This is the superior anterosuperior iliac spine. This is the pointed portion. This is not transtubercular line. You need to go outside. This is the top margin of the hip bone, and this top margin you need to adjust, and that is the transtubercular line. This is the transtubercular line. This is the transtubercular line. So the one transtubercular line, and then one transpyloric line, and then two mid-clavicular line. So we will found total 9 regions. Above the transpyloric line, we found the epigastrium, and in between the clavicular mid-clavicular line, above the transpyloric line, that is we found that the epigastric or epigastric region or epigastrium region, and then in between the mid-clavicular line, in between two mid-clavicular line, and in between the transtubercular line and the transpyloric line, in the middle we found the umbilical region. This is the umbilical region. And then we found below the transtubercular line, in between the that is mid-clavicular line, we found that is hypogastrium. So this is the epigastrium, umbilical region, and hypogastrium. And then you find the above the transpyloric line, just left to the left mid-clavicular line, you will find the left hypochondriac region, and then right hypochondriac region. In the outside of the right side of the right mid-clavicular line, and above the transpyloric line, you can find the right hypochondriac region. Then right lumbar region and left lumbar region. In between the transtubercular line and the transpyloric line, right side to the right mid-clavicular line, you will find the lumbar region, right lumbar region, and the left lumbar region you will find in the mid-clavicular line, left to the mid-clavicular line and of the left mid-clavicular line, and in between the transtubercular line and the transpyloric line. That area is called the left lumbar region. And then inguinal region you will find just below the transtubercular line and left side of the left mid-clavicular line. That is the left inguinal area or inguinal region, and in the just below the transtubercular line and right side of the mid-clavicular line, you will find the right
iliac fossa or right iliac region. And so these are the 9 regions of the abdomen you can examine. Before examine, you need to know this area, and then you need to adjust the thing. And then another way in clinical practice, sometimes we subdivide the abdomen into 4 quadrants just by drawing 2 imaginary lines intersecting the umbilicus. One is the vertical line in the center, and in the center another horizontal line intersecting the umbilical region. One line like this way, another line like this way. Then you can subdivide into 4 quadrants. One is the upper left quadrant and upper right quadrant, and lower left quadrant and lower right quadrant. You can explain like this way also. If you found any swelling in the quadrant, so you can say I found swelling in the right quadrant, or left upper quadrant, or left lower quadrant, or like this way you can understand, or you can say like this way, this region, that is right hypochondriac or umbilical region, or pain felt in the right inguinal region. You need to explain like this way also. So, and then before starting the examination of the abdomen, you need to inspect the abdomen. And inspection of abdomen, you need to start by observing the skin color, and then any kind of rash there or not, and then you need to check the specific any kind of scar mark present there or not. Sometimes we can found in the pregnant woman, or in case of female, that is the stria gravidarum, linea nigra. Also we can find sometimes we can find some spider nevy in case of chronic liver disease patient of the chronic liver disease. So you need to inspect like this way, and also you need to inspect when you inspect the skin color and other thing, rash and other thing, and then you need to check. Then you need to inspect, is there any subcutaneous nodules present or not? Subcutaneous level, subcutaneous nodules, raised nodules there or not, you need to inspect. And then you need to inspect any engorged vein present or not. You need to inspect that one. And also then you need to inspect any visible peristalsis present here or not. Any visible peristalsis present. Peristalsis movement occurs inside the abdomen, but normally it cannot be observed or cannot be seen from the outside. But sometimes it may be shown. That is, in case of such as in case of the small intestinal obstruction, you can see the step ladder pattern of the peristalsis movement. In case of pyloric stenosis, in case of obstruction, large intestinal obstruction, you may see the peristalsis movement from the right side to left side in the abdomen. That is also indicative. So you can see, you need to observe the movement of the peristaltic movement, or that is the observation. And then also you need to check any kind of swelling swelled area here or not. You need to check, and you need to say the patient to cough. Yes, cough. Yeah. So during this one you need to see any kind of swelling appears during coughing. During coughing, any abdominal hernia may happen like this way. So during coughing, it may cause abdominal pressure that may swell up at that time. Normally there is nothing, but when cough, that may appears. That is maybe abdominal hernia. In case of inguinal hernia also, as we expose up to this one, inguinal hernia also sometimes maybe swell up here. Incomplete inguinal hernia also may swell in this area after coughing, but not before coughing. It may sometimes may not seen. And then you need to see the symmetry of the abdomen. Whether it is distended, whether it is squamous, whether it is hollowed like this. You need to see. If it is distended, then you need to see it is related with any specific swelling, symmetrical swelling, or symmetrical distension, or asymmetrical distension. You need to see. Sometimes we found that one patient came to me. Always he took the insulin in one side of the abdomen, just beside the umbilicus. and I found there is a large swelling appears in that side. That side is called what? Lipodystrophy. Lipodystrophy occurs sometimes like so. That will be in disproportionate swelling you may form. Like this way you need to check. And then if it is distended, like symmetrical distended, maybe indicated that is due to the ascites or accumulation of fluid in the peritoneal cavity. So you need to inspect all these things at first, and then you need to palpate the abdomen. Before palpation of the abdomen, you need to tell the patient. If there is any pain in the abdomen, then he need to show that area to you by one finger, not by total hand, not by vague pain. You need to tell the patient need to tell the pain area in the abdomen by one finger. Tell where is the pain. If maybe pain here, if maybe pain in the right iliac fossa, maybe pain here. So before this is called pointing sign. That when you need to tell the patient the specific point out the specific pain area, then if the patient show you the specific point, this point I am feeling pain, then it is called pointing sign. After finding this pointing sign, don't touch that area at first. You need to touch the normal area at first, and before starting palpation of the abdomen, you need to palpate the abdomen at first superficially. Superficial palpation at first you need to do. Superficial. So superficial palpation you can start by placing your hand like this way, dorsum of the hand, to check whether it is the temperature is normal or not. And then you need to start the palpation. If the pain is here, so start palpation from the left side. Slowly, very slowly you need to palpate, very slowly, not deep palpation. This is the simple superficial palpation. And after palpate all other area, then you come to the specific area. You need to see at first the superficial palpation, the patient feeling pain or not. How you observe the pain? When you are observing this area, you need to observe the facial expression of the patient. Sometimes we are checking. The patient told me, here is the pain, and I found that like this superficial palpation I did, and then I make it, and he is laughing. So there is no pain. This pain is vague. Like this way. Sometimes we found that superficial palpation also, when the patient said that there is a pain in the right side, we found these muscles are very guarded here. Not like this. Other area is not guarded by the muscle. But here the muscle is so much guarded by superficial palpation you found. So there may be pain. And when you press there slowly or especially, and then you found this kind of folding in the head, or the patient expression said that patient is feeling pain over there. So you need to check the face when you are superficially palpate, and then deep palpation, In case of deep palpation, at first you need to check. The different region of the abdomen. You need to check one by one. Epigastric region. If patient has any kind of peptic ulcer disease, then he will feel the pain. And then you need to check the lumbar region, and then umbilical region, and then hypochondriac region, and then iliac region, and then gastrium region. And all the region you need to palpate. If you found any swelling in any region, any swelling inside or abdominal swelling in any region, it may be due to one mass, may be related with the large intestinal mass, may be related with the colon cancer or tumor in the colon. It may be, or it may be due to one kind of abdominal hernia, that swelling you found, or swell, or any kind of obstruction also you sometimes may found one swelling. So you need to examine that swelling. At first you need to mention the specific site where position of the swelling, and then you need to check this swelling area is painful or not, painful or not. On deep palpation it is painful or not. Then you need to check the reducibility of the swelling. This swelling is reduced after palpation or not, You need to check the consistency of the, it is hard or soft, consistency of the swelling. You need to check it is pulsatile or not. The swelled area, sometimes the aorta, maybe aortic aneurysm is there, and the aorta is swelled up, and it gives some pulsation. You find one swelled area, and then you find there is some pulsation also. So this swelling area may be pulsatile or not, you need to check. And then you need to tell the patient to cough again. Whether during coughing showing any pulsation or not, you need to check. Is that clear? So at first you need to check deep palpation of all area, and then you need to see is there any swelling or not, present or not. And then you need to check this swelling in details, that is the site of the swelling, then size of the swelling, position of the swelling, and then reducibility of the swelling. Pain is there, it is tenderness you need to check, and then you need to check the swelling may cause any pulsation, or on coughing it is pulsatile or not. You need to check. After palpation of this one, then you need to palpate the liver. The liver palpation, you need to start in the right side, from the right side. You need to start from the iliac fossa, right iliac fossa, and press your finger, that is the index border of the hand. You need to put the parallel to the costal margin. You need to put like this way, and start palpation of the liver from the iliac fossa or iliac region, from right iliac region, and then inch by inch you need to move upside. Inch by inch you need to move upside, and you need to tell the patient to take and release the deep breath. Take deep breath, and when he release, then you press. When he release, then press. When he release, then press. When take the breath, don't press. When release the breath, then when expiration, then you press. When expire, then you press. Like this way, and you need to go up to the costal margin. This is the way of liver palpation. If liver enlarged, if any pathology, due to any pathology, liver enlarged, then you need to check what are the thing. That is the enlarged portion of the liver. What size of the enlarged portion of the liver? You need to measure with the help of tape from the lower margin of the costal cartilage to the lower border of the liver. And upper border of the liver you need to measure. How? I have shown earlier. From the second intercostal space you need to percuss, and then you found one dull sound. When you found the dull sound, that is the upper border of the liver, and this is the lower border of the liver. So size you can determine, and then you need to check the enlargement up to what? It enlarged from lower margin of the costal margin to the lower border of the liver. You need to measure, and then you need to see the edge of the liver, whether it is sharp or rounded. You need to see the consistency of the liver. It is hard, soft, globular like this. You need to see the surface of the liver, whether it is nodular, smooth or rough. You need to check. You need to write all the findings of your examination of the liver palpation. Clear? Then you need to palpate the spleen. The palpation of the spleen, that is in the lower aspect. This is the lower margin of the costal margin. Then just above the costal margin, you need to place your hand. In the left side. This is called hypochondriac area. And then palpate with your fingertip. From the right iliac fossa.
and tell the patient to breathe deep, and then you need to see the spleen. As spleen can grow or can enlarge like this area, this way, from the left side towards the umbilicus or towards this fossa, that right iliac fossa. So you need to check from here. You need to check from here. If sometimes you are thinking that this spleen is enlarged, but you cannot feel from this action or this examination, you cannot feel any swelling, then you can check the fold like in the left lateral position, and then hold the hand onto here and then press like this way. Like this way. Spleen you can check. Spleen you can check. And if it is enlarged, then you need to measure from the lower margin of the costal, lower costal margin to the tip of the spleen. There is the palpation of the spleen, way of palpation of the spleen. And then you need to palpate. You need to palpate the aorta. Palpate the aorta. The aorta palpation, you need to place your both the hand in the just left side of the abdomen, left side of the umbilicus, and just tell the patient to make this muscle guard very easy. Don't make it hard, don't make it contracted, and then you need to press like this way, and then you can feel the aorta. Slowly, you will not feel any pain. Then you will feel the aortic pulsation also. And during this time, it is very tough in case of that obese person. It is very tough. But in case of lean and thin person, it is easy to palpate the that aorta from here, abdominal aorta, and also you can check the abdominal paraortic lymph node. Also, you can check by this position. From this position, this is the palpation of the aorta. Then you need to palpate. The kidney. That is the right kidney and left kidney. Put your left hand just in the loin region. No, in this position, supine position, in the loin region. Loin region means just below the costal margin, and above the upper margin of the hip bone. Upper margin of the hip bone. In between this area, you need to put your left hand. You need to put your left hand in the back side, and then press in the lumbar region. Then press to the deep and upward, deep and upward. Then if the kidney is swelled, then you can feel the kidney. In the right kidney, you need to check like this way. Place your left hand that in the loin region, and then place your right hand over there, and then move slowly inside, and tell the patient to relax. Not guarded the muscle, and then you can palpate the kidney. This is the process of palpation of kidney. Clear? And then palpation of bladder, urinary bladder. The palpation of bladder cannot be palpated if the bladder is empty. If the bladder is empty, you cannot palpate the urinary bladder. But if the bladder is full, then you can palpate it like this way, and then you can feel the upper border of the urinary bladder and the left border or lateral border of the urinary bladder, and lower border cannot be palpated. Bladder when full, it can be palpated like this way, and the full bladder can be extended up to the umbilical region also. So you can palpate like this way, and then you need to palpate the lymph node, that is the inguinal lymph node. Inguinal lymph node you can find in the line in between the symphysis pubis and the anterosuperior iliac spine, and in this line you need to check there is any swelling or not. Then the process of palpation of abdomen. After palpation, we need to do the percussion, and then auscultation. Percussion. In case of percussion, Percussion. We need to percuss the urinary bladder first. Now retention of urinary bladder, then it is distended, and you will found the dull sound there. You will found dull. This is dull sound. See, dull sound. Dull sound. Just feel now. This is tympanic sound. See the tympanic sound. This is dull sound. This is
खाली करा है
this is tympanic, and this is dull sound. This is dull sound. This is dull sound. Go to it.
खाली करा है
Shifting dullness. Shifting dullness, you need to check from upper abdomen. Tympanic sound. This is the tympanic sound. Up to the umbilicus. You need to come, and then you need to move. Then you need to move to the right side. Then you need to move to the right side. Such as when patient in the supine position, fluid are accumulated here. Fluid are accumulated here, and then you found dull sound. You found, I am not finding any dull sound here. If you found dull sound here, then stop. Then don't move your hand from here, and then tell the patient to move in left lateral position. Don't move your hand from there where you found the dull sound. Then keep the patient like this way for 30 seconds. You need to count by your watch 30 seconds, and then after 30 seconds, just tap again here. If it is tympanic, then it indicates the fluid is moved to here. At first it was dull, but now it is tympanic. So it is shifted. This fluid is shifted as you move like this way. So it is called shifting dullness. And then you need to tell the patient again like this way, and then you need to move this percuss this area to this area. Here, if you found the dull sound, then tell the patient to move in right lateral position again, and then wait for 30 seconds. Don't move your hand where you found the dull sound. Don't move your hand, and then press onto that area after 30 seconds again in this position. Don't make the patient again supine. In this position you need to check whether it is turned into tympanic or not. If it is tympanic, that means the fluid is shifted here. So this is called shifting dullness test. Clear? This is called shifting dullness test. And then fluid thrill. Fluid thrill. Fluid thrill means such as a bag of water you have here. A bag of water. It is, the bag is not clear. Water you cannot see. You put here this one, and then you place your hand this in this side and just tap the water from this side. Tap the water from this side. You can feel some vibration of the water in this hand. This also can happen here if fluid is there. If fluid is there, so you can tap, and during tapping you need to feel, yes, I am feeling some vibration. I am feeling some vibration. This vibration is for fat. This vibration I am feeling due to the fat transmission. This vibration is transmitted through the fat. To remove this one, just you need to tell the patient to place his hand like this way, and so, and then you place your left hand in this side, in this flank, and then just tap onto this area. So this hand will prevent or cut off the vibration of subcutaneous tissue. Only fluid, if fluid is there, you will feel some vibration onto this hand. This is called fluid thrill. Is that clear? Another thing we also need to do, that is called succussion splash. Succussion splash. This succussion splash occurs due to the paralytic ileus most commonly. Due to the paralytic ileus, most commonly we found this succussion splash. Succussion splash means you can take some water water in a kolshi. What is the English version of kolshi? Water pot or water jar, rounded water jar. You can take some water in the water jar and half filled jar water and some air, and then you can move water in that jar. You will sound one sound, proper sound. This sound you can feel when you move. You can hold the patience that this one is a region of the hip bone, and then you need to pull and then move like this way, and then here you will hear that kind of sound. If you hear that kind of sound, that is called a succussion splash test is positive. And commonly we found in case of paralytic areas. Paralytic areas, don't move like this way. Will not hear. You need to pull. You need to pull up, and then place it here, and then move. So you can find the succussion splash sound. Succussion splash sound, and then auscultation. Auscultation, you need to auscultate first vowel sound. First thing is the vowel sound. Vowel sound is very much important thing, as because if vowel sound is absent, that means there is some pathology present in the abdomen. If the vowel sound is increased, that is also some problem. Checking of vowel sound is very important. You need to start from the right side of the umbilicus. Start from the right side of the umbilicus. You need to place the stethoscope. You need to place the stethoscope onto the right side of the umbilicus in the inguinal region. Then you need to wait. How much time you need to wait? If you hear the sound, then okay, you can move out. But if you are not hearing any sound, then you need to wait for at least 1 minute. You need to wait for at least 1 minute. Then you need to check from the left side also. You need to check from the left side also. If you find the sound, then okay, you can move out. But if you not found the sound, then you need to place the stethoscope for 1 minute, at least 1 minute. And what are the causes of increased vowel sound, and what are the causes of absent vowel sound? What are the causes of decreased vowel sound? You need to see in the book. You need to auscultate any bruit present in the artery, left side of the umbilicus. You need to put the stethoscope and then deep. If you found any bruit sound, that is due to the aortic aneurysm. You need to place it into the iliac fossa to find the iliac arterial bruit in the right side and left side. And you need to place it onto the femoral arterial to find out any bruit present onto the femoral artery or not, like this way. So you need to check, auscultate the bruit, and then we need to auscultate venous hum. Venous hum is produced due to the increased blood flow. Actually, the bruit also caused due to the increased blood flow inside the artery. Increased blood flow inside the artery causes the bruit. That is aortic aneurysm, or in case of atherosclerosis in the aorta, that may lead to the presence of the bruit. And venous hum in between the Gifford process and the umbilicus, you can find some sound, harsh sound. That is called venous hum. Then you need to auscultate any friction sound, such as there is any infection present in the peritoneum. So that may produce the friction sound. Most commonly it happens due to the abscess, perinephric abscess and other abscess. Due to that, this friction sound may form in the abdomen. And then we need to check the lower extremity. You need to inspect any any kind of there is injury, abrasion present onto the onto the knee, onto the knee. So you need to check this. And local examination you need to do. Local examination you need to do. That there is the swelling. Is there any swelling? Is there any pain? Is there any secretion? Or is there any other findings? You need to check. And then the inspection, on the inspection, you need to find out any kind of rash, or you need to check any kind of deformity, any kind of shortening of the leg, where any one leg is shortened or not. You need to check any kind of abnormality, swelling of the joint, any kind of joint swelling is there or not, any kind of color change of the skin. You need to check, or you need to check any kind of muscle atrophy, or muscle hypertrophy in all lower limb. You need to inspect first, and after inspection you need to check the edema. You need to check the edema of the edema in the lower limb. At first, the way of checking the edema is with the both hand. This thumb you need to put just above the medial malleolus and press it for at least 30 seconds. Press it over there for at least 30 seconds. And then you need to check whether there is any pitting edema or not. Remember this thing: if this pitting area remains for more than 1 minute, then it is edema. It will not remain for more than 1 minute. So you need to check this one, and then 30 seconds, and then withdraw, and then you need to check this pitting may remain for more than 1 minute. Then you need to see, you need to say that this is edema. And then another one, you need to check from the shin of the tibia. Both finger you need to press onto the shin for 30 seconds, and then you need to remove. And if there is any pitting area present, and if it is remain constant for more than 1 and 2 minutes, then there is present. Muscle tone, muscle power, and joints we need to check. So in some cases, so you need to check like this way. This is the examination of tone of the muscle, and then this is normal tone. This is the normal tone. This is the normal tone. Yeah, this is the normal tone. And then you need to check the muscle power. You need to check the muscle power. Muscle power checking, you need to tell the patient to move his leg upside, up, and firm pressure on it. Yeah, fine. And then firm pressure. Okay. Yes, this indicates the extensor muscles are okay. Extensor muscles are okay. And then you need to tell the patient to flex the knee. Yeah. So the flexor muscles are okay. These flexor muscles are okay. Okay, relax. And then this one. Yeah, it's okay. And then you need to tell the this one great toe to move upside. Yeah, that's good. This one finger. Yeah. Then and then press, and then press. Good. Then press, and then press, and then you need to check the joint. All joints are moving, active and passive. Active is you need to tell the patient to plantar flex and dorsiflex. Move plantar flex and dorsiflex like this way. Plantar flex and dorsiflex. There is no pain and other. And then you need to do by passive movement. This is a plantar dorsiflexion and plantar flexion. Is there any problem? You have seen. You need to check. This is a passive movement. You need to check active movement and passive movement. And then you need to tell the patient to fold the knee. Move the both knee and straight. Make it straight. Is there any pain or not? You need to ask. or is there any problem, feeling problem or not? And then you need to tell the patient, to flex the hip. So it is okay or not? And that one also, the flexion extension you need to check. Flexion extension, and in case of knee joint, flexion extension also you need to check, and also you need to check the adduction and abduction. Do adduction and abduction, and move it that way, and then abduction, and then adduction, and then this after checking the joint and the movement, the active and passive. Then passive movement means you need to flex the knee by yourself. And this is the passive. Sometimes active movement causes no pain, but passive movement causes pain. You need to remember like this way. And then you need to check the arterial pulsation. When you have checked here, and then you need to check the arterial pulsation of the lower limb. What are the arterial pulsation of the lower limb? That popliteal artery. Just move the leg easy, and then place these 3 finger at a time here. You'll feel the pulse. Popliteal arterial pulse. Like this way you can check the popliteal arterial pulse. Sometimes also we can check this popliteal arterial pulse by prone position. I will show you when the patient will turn into prone position. And then you need to check the posterior tibial arterial pulse. By placing your hand like this way in the posterior tibia. This is posterior tibial arterial pulse, and then you need to check the dorsalis pedis arterial pulse. Here, this is the dorsalis pedis arterial pulse. A straight leg rising test. You need to tell the patient to raise the one leg, and it is normal is 80 degree to 90 degree. It is normal. And then you need to tell, and then move this way, and then you need to fold it, and then you need to press. If the patient is feeling any pain in the back, you need to ask. If it is reduced, not more than this, the patient cannot move his leg, then you need to move slight below than his range, and then fold, then make it fold. If there is any pain, so root compression or any compression occurs into the sciatic nerve, you can check like this way. Both leg you can check like this way. So you can pull this. So it is almost 90 degree. Then come to less than 90 degree, and then fold it, and then press it like this way. If you need to ask whether there is pain in the back or not. A straight leg rising test, and then the knee jar and ankle jar. At least these 2 jar we can check during the general examination. And another one we need to check the hammer. Another one we need to check the plantar reflex or Babinski sign. So plantar reflex and this one, how we can do? One way of checking the knee jar is patient will be in lying position. And then move your one leg like this way, and another leg also like this way, and then put your hand like this way, and then you can pull this leg very clearly, very nicely. Is that clear? And actually, so you need to feel the tendon. Which tendon it is? Quadriceps tendon. You need to feel the tendon. And then just press onto the tendon. Just place onto the tendon. And another thing, if you do not expose the front of the thigh during examination of knee jar, you will be failed. As because you need to check the knee jar not moving the leg. You need to check the muscle is contracted or not. Is that clear? So press here. Yes, it is contracted. It is okay. And then you need to check this one. So move this one also, and then you can pull like this way, and then you can press. Oh, there is no problem. So you need to check the quadriceps muscle, whether it is contracted or not. This is the knee jar. This is the knee jar. And then you need to check the ankle jar. You need to check the ankle jar. One of the way. This is the one of the way of checking the knee jar. And one of the way of checking the ankle jar in lying position, supine position. Flex the knee at first. Flex the knee at first. And then press the hammer onto the tender Achilles. You need to check this muscle. You need to check tender Achilles onto the tender Achilles. Yeah. And then fold this one. Exaggerate. Yeah. There is contraction. This one is this is called ankle jar. This is called ankle jar. This is due to the nervousness. Now he is very nervous. That's why. And then you need to check the plantar reflex. Plantar reflex. The plantar reflex you can do with This one is for what? For sensory test. For sensory test. And sensory test we do not do now. In general examination, we do not need to test the sensory test. And then you can do one thing. One blunt. This key also enough. But it should be blunt. It should not make any injury. It should not make any injury. You need to check whether it is sharp or not. And then see this one. From here you need to see. See this one. You need to put this key and move from this way to this way, and so it will move to plantar flex condition. Plantar flex. This is the plantar flex reflex. Okay, this is the plantar flex. And then this one. This is the plantar flex. This is the plantar flex. This is plantar flex. This is plantar flex movement. So it is when we tell it is Babinski sign positive. If this movement is dorsiflex, then Babinski sign is positive. This is the plantar reflex. This is the plantar reflex. Sometimes I pull this one in the lateral side, from the lateral side to the medial. From the lateral side to the medial. Sometimes it can be done by this way. Simple. Sometimes it can be done by this way. Middle. Like this way. Is that clear? Is that clear? So this is the plantar reflex. Now we need to examine the patient from prone position. So we have examined the patient in sitting position, and then we have examined the patient in lying position and supine position. Now we need to check the patient from prone position. In prone position we need to inspect the patient from back. Is there any swelling? Is there any problem? Is there any deformity or any kind of rash or anything is there? And hair distribution and other things you need to check. You need to check in all parts of the body. This is the inspection. This is the inspection. Very easy. Normal. Very easy. Sorry. So we need to check. We need to check the spine. We need to check the spine. We need to count. There's a prominent one is the 7th cervical vertebral spine. And then you need to count. This is the 12th. And then you need to check whether there is any scoliosis or any kind of kyphotic change or any kind of lordotic change. And is there any pain? Is there any swelling or any abnormalities present in the spine? You need to palpate. And then you need to check the sacral edema. Just press one finger on the coccyx. Press for 30 seconds, at least for 30 seconds. And then remove. If there is any pitting edema present, then there will be depressed area present for at least 1 to 2 minutes. That is the sacral edema. And then we need to palpate the renal angle. This is the vertebral column. This is the vertebral column. You need to palpate. Then this vertebral column and the lower border of the costal margin. This junction point is the renal angle. This junction point is the renal angle. You need to palpate the renal angle. You need to palpate the renal angle whether there is any pain or not. In case of renal stone, in case of perinephric abscess, this renal angle shows some pain. And then popliteal arterial pulse. Popliteal arterial pulse we have seen from the supine position also by pressing two finger and then two hand. And also you can check like this way. Like this way you can check the popliteal arterial pulse in the popliteal fossa. In the popliteal fossa you can place this one and then you can check the popliteal arterial pulse. You can check the popliteal arterial pulse. Yeah. So like this way you can check. This popliteal input also you can check from here by palpating the area of the popliteal fossa. And then ground position to check the femoral nerve. If there is any problem in the femoral nerve, the compression in the femoral nerve or any nerve damage, injury. So you can tell the patient to move or flex the knee like this way and flex the knee like this way. And range you need to see whether the patient is feeling pain or not. Here you feel any pain? No. Now you are feeling pain?
No.
Now? No. So there is no problem. We are stressing the femoral nerve like this way. Even stressing also it will feel no pain. There is a femoral nerve test which is negative. And now you need to check the sciatic nerve test again like this way also. You need to tell the patient to move the leg straight up. If there is any problem in the sciatic nerve, the patient will not allow to move this leg up to this way. He will not move like this way. He will up to this, then you will tell there is pain like this. Okay, so move. This is the sciatic nerve test. Sciatic nerve test, and that test is for sciatic root compression test. This is for sciatic nerve test. And then you need to tell the patient to stand here. To stand here by like this way. You need to stand and straight, and then close your eyes. For at least 1 minute, the patient needs to stand like this way. This is called lumbar test. If the patient fall down during doing this test, you must need to stand beside the patient. You need to observe the patient. If the patient fell down, that the lumbar test is positive. So he cannot maintain his posture. And then you need to tell the patient to walk on a straight line. Any limping, any kind of weakness, is there, you need to check. During this walking, you need to check like this way. And another thing, tell the patient to sit in the floor. Yeah. And then stand up. Or you can sit like this way and then stand up. Yeah, stand up. This is called Coerce test. This test is very important if there is any proximal myopathy. So patient will do like this. He will sit like this way, and when I tell him to stand up, patient cannot stand up. Then he start doing like this way, and then he is straight, and then this way, and then this way, and then straight. Proximal myopathy. If there is proximal myopathy, so this is the Coerce test positive. And then tendinous part test. You need to tell the patient to move his one leg up. So see, when he move up this leg, this hip bone move upside and this one move downside.
or almost same. But if there is any problem related with this muscle, gluteus maximus muscle, then this one will move downward and this one will move upward. That tendon part test is positive. That tendon part test is positive. So if there is any problem related with this muscle or this muscle, you can check this tendon part. These are the special tests you can do in general examination also. We do this kind of in general examination also. We do this thing. So this is the finish.